Good evening, friends. Today's video is special. We are in the middle of the novel coronavirus pandemic, and we have a renowned scientist as a special guest with us to tell us more about the virus that is at the center of the problem. Joining us this evening, we have Professor James Hogle, Edward S. Harkness Professor at the Department of Biological Chemistry and Molecular Pharmacology, Harvard Medical School, and a former chair of the Harvard Biophysics Graduate Program. Welcome, Jim. Welcome to the show.
Hello, Shantanu. It's good to see you again.
Professor Hogle's research has actually focused on two major areas. I believe that they're about the cell entry pathways of polio and related viruses, very similar to coronaviruses, and the replication complex of and nuclear egress complexes of herpes virus. Am I correct?
That's right.
Yeah, so Jim, tell us more about this virus that we are all running scared of. The coronavirus is similar to the polio virus, is it not?
Well, it's a much bigger virus, and it's more complicated in a lot of ways. Polio is a virus that has, we speak about the size of its genome. They're both have RNA genomes. They're both single-stranded RNA genomes. Polio has about 7,500 nucleotides. Coronavirus has about 30,000. And that's very significant thinking about this virus because most single-stranded RNA viruses like polio, when they replicate, they make about one mistake in every 10 to the fourth corporations. And that means that you get a mutation basically almost every time you do a replication, you get a mistake made. Most of those just disappear because they're not fit, but sometimes they have an advantage and they stay. Coronavirus's genome is large enough that it could survive if it had that high an error rate. And the coronaviruses, what they've done is incorporate an error correcting mechanism that if they make a mistake, they cut it out, and then after it's cut out, they go over and try again. So they have a much lower error frequency than most RNA viruses. And what that means that their mutation, that the rapidity in which they fix mutations is somewhat slower, in spite of the fact they have this much larger genome. The significance of that is that should we be able to develop a vaccine or an antiviral drug, the rate at which it would make mutations and escape those would be somewhat slower than other RNA viruses. So the prospect for that's the one bit of really good news in here is that it is less prone to becoming resistant to vaccines or resistant to antivirals. Of course, the bad news is that this virus happens to be very infectious by predominantly aerosol and surface routes. And it also has a very high mortality, especially amongst people that have compromised immune systems or existing conditions with the cardiovascular system.
Absolutely. Even diabetic conditions. Even diabetes, for that matter, I think that would compromise the immune system more.
Yep. And so, what we're seeing is a very high mortality in people that are age and higher, especially in people that are 80 years old and older, and obviously in patients that have compromised immune systems, and this would include, of course, people that are on cancer therapies. So it's a very frightening thing in that regard. The good news is it's less likely to cause serious issues in healthy children.
So does it mean that it is less dangerous to the children? So I see that in Italy, so many people who are old who have died.
I think one of the difficult things when we talk to general public is that when we say it causes serious health problems, less frequency in children.
Uh-huh.
That doesn't mean it doesn't cause serious problems in children. Children have died of this. There are children that have, lung problems, that children that are immunocompromised, and even healthy children have gotten very, very ill from this. It's just they are less likely than adults. But of course, even if children got no disease, they then pass it on to their parents and their grandparents and the outside world. So the fact that they aren't as sick.
Yeah, so even asymptomatic for that matter. So how does it enter the human system? So how does it infect your lungs?
Well, it comes in for sure by through aerosols. And there are a couple of types of aerosols that we talk about when we're talking about respiratory viruses. One travels only in large droplets, and that's the droplets that happen when you cough or you sneeze. And they tend to not travel large distances because they fall. So that means this is social distancing, saying a meter or 2 meters away from people at all times is practice. The other kind of aerosol transmission is very small droplets, and those can travel a long time and last a while. And right now it appears that the predominant route of transmission of this virus is by the larger droplets, which is a good sign. It also means that it's easier to protect others if you're sick by wearing a mask.
By wearing a mask, yeah.
Well, you're protecting others. And then, of course, and even simple masks would work, are better than nothing. If you're having symptoms for protecting other people. Of course, what the real issue is that the people that are involved in critical care patients need higher grade medical equipment, and this is why people right now are saying let's save some of the higher grade medical equipment for the physicians and other frontline responders that we're desperately short of.
Yeah, absolutely. So it's also an ethical question, remember. So it's like, so you're letting some people die because you're triaging, because your health system cannot cope with the system, with the pandemic.
Well,
this
is what happens in areas where the very rapid increase in number of patients swamps out the medical care system. And this has happened in places. It happened in Yunnan. It's happening in the north of Italy. It's beginning to happen in other areas of Italy. And yes, then the physicians having to make the decision of who gets the critical care treatment. That's a position that is very difficult for physicians to make. They want to help everybody, and there comes a time when they can't. But that's the frightening thing about this is that the growth in local populations tends to be very fast.
Yeah, absolutely. So if there is a local transmission, if there is a community transmission, that is. So is there any test? So the people who want to test it, like Germany has done a widespread testing in the community. Even South Korea did that. So is it an advisable strategy to do it and test and isolate treat?
Early on, and in the end stages, that is absolutely the best way to go. If you can identify the cases early on and isolate everybody that is infected, that at that point you have much better chance of stopping the transmission rate. At some point, it's hard to test enough people, and that's the point that when you just say, okay, everybody stays at home, which is what is happening in many states in the U.S., in much of Europe. It's happening, it's beginning to happen in India as well. And that's when you outstrip your ability to test. But the ideal situation for any epidemic, especially respiratory disease, is widespread testing and isolation of positive cases. We've just kind of exceeded our capacity to test right now, and therefore the only thing you can do is assume everybody is possibly infected, and therefore everybody needs to be isolated from everybody else.
Yeah, absolutely. So is there any test that can detect the COVID-19 cases correctly, even if the viral load, say, for example, in the body is very, very low, like early in the infection stage? So
this depends on the test, and it depends on who runs the test. Any test has the possibility of negative results. A false positive is worrisome to somebody that tests positive, but if you go up and do a follow-up test and show that no, that was correct, then from a public health standpoint, the person is annoyed and scared, but you've not taken and told somebody they're fine, go out and circulate in the world. The false negatives are the things that are worrisome, and then of course in any test there is a sensitivity level. In any test there's a noise level, and at some point the test is in danger of telling someone that they're not infected when in fact they are. Now the best of the tests have a very low false negative rate. Some of the more rapid tests, and again this depends on the test, the way it's being run. Some of the more rapid tests are really great for high virus loads, but are in danger of giving false negatives for the low virus loads. And those are things that we have to be very careful of, because if you're going on the assumption that you can test and isolate, that is, that anybody that is positive, you test everybody, anybody that's positive is isolated from everybody, from the people that are not, then a false negative is very dangerous.
No, so that actually brings me to the next part of the questions. People have been talking about chloroquine, hydrochloroquine, and zinc sulfate as a treatment. Or what about vaccines? If we develop a vaccine, so it's very similar to polio virus, right? So we have a vaccine for the polio. Can't we have a vaccine for the coronavirus?
But you have to remember that it isn't as simple as that. The vaccine against polio, and they are similar only in the sense that they're both small and they both have RNA genomes. A vaccine against polio, probably a better analogy would be but even then it's imperfect as a vaccine against flu, because flu changes rapidly. Therefore, you have to develop a new vaccine each year.
Okay.
But the polio vaccine, of course, was decades of research in the making. We can do it faster now. That's no guarantee that you're going to have a vaccine that works. HIV has been around since the seriously epidemic form since the early 80s, early to mid 80s.
And we still don't have a vaccine.
So there's no guarantee that a vaccine is forthcoming. There's some encouraging comparisons, which is to say that when SARS was an issue, and SARS is a very, very closely related virus. When SARS was it's a coronavirus, and a number of years ago, there was a epidemic that again started in China, and it spread a bit and then died out. They had some very promising early results with vaccines against SARS. Unfortunately, when the SARS stopped being an epidemic, that research was stopped. But we do know a little bit about how to do it, and we have a lot better toolkit now than we did 15 years ago. So, but if we're going to see a vaccine, I have to trust the numbers of people that like Tony Fauci, who is thought to be experts on this. We are probably at least a year out, possibly more like a year and a half, if our ideas work, of having a vaccine that will be ready for general use in the public. There'll be some trials with limited numbers of people, but first you have to show that it is safe and effective before you go and test it on everyone. Now, the drugs, on the other hand, you mentioned chloroquine and hydroxychloroquine. There is another drug that has been used for Ebola, has been used for a couple other viruses, that is also being tested. Those are existing drugs that were developed for something else, and they may help. And right now, that's the fastest route to get something. If you can test them quickly and show that they're effective, and especially if they're effective against people that are already showing serious symptoms, if you can relieve that, stop that from getting to the stage where it's critical and they need ventilation, that would be great. But they're going to be, anything that was developed for something else is likely to be imperfect. And the best of the drugs are things that are going to be developed in this particular virus, and they're also months to a year, at very optimistic estimates, months to a year off.
Yeah,
so we're going to have to just ramp up the research and hope for the best in these cases. But we can't take and promise somebody that I will be able to come up with a drug that will stop this epidemic altogether, come up with a vaccine that means we never have to worry about it coming back. We can't make promises to say that's going to happen in the near term.
Yeah, so some of the doctors in France and Germany and elsewhere as well, so they are treating patients with the plasma of recovered patients. So is that a viable solution right at this moment?
It is a solution that has worked in a number of incidents. You have to realize that it is probably not the solution that one would that it is not the solution that one would choose if you were choosing.
Absolutely. So we have to have a treatment and a vaccine, right? So this is just a stopgap solution.
But again, if we're talking about trying to something that will be used in hundreds of thousands or millions of people, this is something that's going to be very difficult to do with the plasma of recovered patients. If we're talking about saving some of the most critically ill, then we're talking about essentially compassionate use, emergency basis, and anything you do is likely to be better than just letting it proceed. Then in that case, this is a very viable strategy. And in stamping out early cases, it's a viable strategy. It's probably going to be very difficult to roll out population-wide.
So we are stuck with a situation like, so we have to develop a vaccine and prophylactic treatment for this, right? So using some drugs.
The vaccine is actually quite critical because one of the things that we have to remember is that although this is a new and particularly dangerous coronavirus, coronaviruses are widespread, not just in bats and other animals. There are already a number of coronaviruses that are frequently circulate through the population. It's just that they cause very mild respiratory disease. It's all upper respiratory, and they cause. They're one of the major causes, one of several major causes of the common cold. But they just keep coming back, one particular virus comes in and it gives you cold one year, and the next year it's another one,
and that's why you have to have a flu shot every year, right?
Well, the flu shot every year is because that virus changes every year, so you have to have a flu shot every year. But one of the questions, of course, comes up with any vaccine is how long does it protect you? But at the very least, if we come up with something that keeps this from coming back in the next couple of cycles, then we have a chance of essentially stopping this virus from becoming something that is just, we talk about viruses that are just with us, and we tolerate them. And the common cold viruses are amongst them. But it'd be very nice if we didn't have to worry about this one coming back. And the vaccine probably is the only way to do that. No matter what, vaccines are cheaper than drugs because you only have to give them a couple times, whereas drugs you just have to keep giving, basically.
Oh, so there you are, friends. That was Professor James Hogle talking about the coronavirus. Good night, all. We will be back with another guest very soon. So stay tuned. Thank you very much.
Thank you, Shantanu. Thank you, Shantanu.